আমরা আগে হার্ট ডিজিজ পড়েছি, কিন্তু হার্টের ডেভেলপমেন্ট বা ডেভেলপমেন্ট অফ দ্য ব্লাড ভেসেলস এ সম্পর্কে আমাদের কোনো আইডিয়া ছিল না। অ্যাডাল্ট কনজেনিটাল হার্ট ডিজিজ ভার্চুয়ালি একটা নতুন টার্মিনোলজি, যেটা এসছে ইন দ্য ইয়ার অফ 2018। পাঠ্যক্রম এসেছে 2020 সালের পর থেকে, আর আন্ডার গ্র্যাজুয়েট কোর্স এসছে 2022 সালের পর। প্রিভিয়াস কনসেপ্ট রিগার্ডিং দ্য অ্যাডাল্ট কনজেনিটাল হার্ট ডিজিজ, সেক্ষেত্রে অনেকখানি শিফটেড হয়ে গেছে আইডিয়া ফ্রম দ্য ম্যানেজমেন্ট পয়েন্ট অফ ভিউ, from the definition as well as from the diagnostic strategy. Now, our journey from the congenital heart disease to adult congenital heart disease should be done through several processes. Number one, cardiac morphogenesis by the process of embryogenesis or development of the heart and blood vessels by means of embryogenesis. Then any defect in the process of embryogenesis that may result in the development of congenital heart disease. Then the detection of congenital heart disease at birth. Then the subsequent management of congenital heart disease with a view to the prolongation of the survival into adulthood with the presence of the congenital heart disease. This is the sequence of journey. Now first coming to the point of congenital heart disease before going to the actual topic of adult congenital heart disease. Congenital heart disease basically means structural defect originating in the fetal life and present since birth and undergo alteration or modification in the postnatal life. Then the Acyanotic classification and the Cyanotic classification. Now the first point in discussion is the etiology of congenital heart disease. What are the etiologic point of view that should be summarized? That should be summarized in a concise manner. The four pillars of congenital heart disease etiology. Number one, genetic endowment. Number two, chromosomal aberration, especially trisomy 21 and others. Number three, maternal lifestyle and maternal illnesses, especially rubella virus infection or Zika virus infection. Maternal lifestyle modification, that means exposure to alcohol, smoking, and other teratogens. So the four pillars of congenital heart disease etiology: number one, genetic endowment; number two, chromosomal aberration; number three, lifestyle and behavioral pattern of the parents, especially the mother; and lastly, the maternal illness. Genetics, chromosomal aberration, maternal lifestyle factors, and maternal illnesses, especially rubella and Zika virus. Rubella is associated with persistent tuberculosis and congenital pulmonary stenosis. Infectious agent, rubella, can cause deafness, cataract, and heart defect, especially again the persistent ductus arteriosus. Maternal illness such as diabetes mellitus, systemic lupus erythematosus, maternal metabolic diseases, phenylketonuria, and others, and exposure to the teratogens like drugs such as thalidomide or some anticonvulsant drugs. Now, cardiac morphogenesis, that means development of the heart and blood vessels in the process of embryogenesis. The first is introduction regarding the embryological point of discussion. Event are ovulation, formation of the zygote, then cleavage, then 16 cell stage, that is the morula. Cellular differentiation and progression leads to blastocyst that again undergoes the subdivision inner cell mass or embryoblast, outer cell mass or trophoblast and blastocyst. In the outer cell mass or trophoblast, there appears a that is subdivided into three components with the phases of development, such as ectoderm, endoderm, and mesoderm. In the mesoderm appears a cardiogenic plate. In the cardiogenic plate, the initiation of cardiac morphogenesis starts. First appears the primitive tubular hearts, then fusion of the primitive tubular hearts from cranial to caudal end, with the exception of the caudal part that remains both right and left arm. Now the developmental timeline or sequence. Day 18, cardiogenic region forms. It is day 18, development of the primitive heart tubules in the cardiogenic plate. Day 22, tube fusion with the exception at the caudal part. And 4 weeks cardiac looping begins. That means the primitive tubular heart, Anatomic undergoes a rotational movement, assuming a S-shaped configuration. Then the weeks 5 to 7, septum of atria and ventricles, and by the end of the 8 weeks, development of the cardiac, the development of the heart and blood vessels is complete. So, the classical four-chamber cardiac configuration is usually complete by the end of 8 weeks, or in certain texts by the end of 6 weeks, whatever it may be, by the end of 6 to 8 weeks. This is the primitive heart tubes. This is the primitive tubular heart that undergoes certain circulation and constriction, producing sinus venosus, right horn, left horn, then the AV canal, then the primitive ventricle, then bulbus cordis, then the truncus arteriosus. Vision of the heart tubes. Again, this is the primitive heart tubules. This is the primitive tubular heart. This is the process of circulation and constriction. This is the process of cardiac looping. This is the A7 configuration. Now, the full-blown picture, particularly embryonic structure after fusion of the primitive heart tubes, coupled with the constriction and circulation, producing sinus venosus, designed for the blood inflow, that is the venous blood. Then the primitive atrium, this is the AV canal, here arises the endocardial cushion. The two fibrous tissues, one from the ventral aspect, another from the dorsal aspect, fuses and produces the endocardial cushion. Then comes the primitive ventricle, then the conoverticular canal, then bulbus cordis, then truncus arteriosus that produces pulmonary arterial trunk, and the aorta, that is the blood outflow, that is the arterial. This is the venous blood inflow, this is the blood outflow, that is the arterial. বালবাস কর্ডিস আলাদাভাবে ডিসকাস করা যেতে পারে, কোনো কোনো টেক্সটে বালবাস কর্ডিস এবং ট্রাঙ্কাস আর্টেরিওসাসকে একই সঙ্গে রাখা হয়। বালবাস কর্ডিস ইউজুয়ালি the proximal part contribute to the formation of the trabecular part of the ventricle. This is the proximal part, trabeculated part of the right ventricle. Conus cordis, that is the outflow tract of the right ventricle, and truncus arteriosus, that by means of EP septum, that is the aortopulmonary septum, produces pulmonary arterial trunk and the aorta, ascending aorta. The sinus venosus right horn is incorporated into the right atrium, and the left horn regresses with the production of the coronary sinus. This is the fate. Now the AV canal connect the atrium and ventricle, and the valvulogenesis from the endocardial cushion and from the endocardial aspect of the ventricles. Lastly, the septal shunt, that means persistence of the foramen oval or persistence of the ductus arteriosus. Formation of atria, ডিটেলসে যাচ্ছি না। ইনিশিয়াল ফর্মেশন ফ্রম দ্য রুফ তৈরি হচ্ছে সেপ্টাম প্রাইমাম, ডাউনওয়ার্ড progression towards the endocardial bar, producing a gap known as ostium primum. Then by the side of the septum primum arises the septum secundum that covers or may not cover the foramen oval. The septum primum, septum secundum, and the presence of the patent foramen oval. Now formation of the ventricle, intraventricular septum, that has got two part, muscular part and the membranous part. Defect at any level may produce PST. Complete closure of the IV foramen occurs by the end of the 7th week. Exterior changes, that is the cardiac looping and the arrival of the spiral AP septum producing ascending aorta as well as the pulmonary arterial trunk. Separation of the great vessels. This is done by the spiral fashion by AP septum. Development of the heart valves. AV valves develop from the proliferation of the subendocardial tissues and the endocardial cushion. Semilunar valves arises from the aorta and pulmonary artery that produces multivercles. Cardiac conduction system. Day of the first heartbeat, it is the 22nd day of gestation. 22nd day of gestation, the day of first heartbeat. The heart is the first functional organ to be developed in the process of embryogenesis. By the fifth week, the AV node and bundle of his will develop from the cells of the AV canal region. যদিও heartbeat শুরু হয় 22nd day of gestation, in the complete genesis of the conduction system takes about 5 weeks. Now clinical correlates. Physiology, a defect in the interventricular septum as well as a defect in the abnormal atriopulmonary septum, transposition of the great vessels, failure of the AP septum to spiral, persistent truncus arteriosus, complete failure of the genesis of the outflow tract, atrial septum often involve failure of the fusion of septum primum or secundum. These are the consequences of the embryogenic defect. Now the fetal circulation. After development of the heart, including great vessels with valvogenesis and the genesis of the conduction system. The second point is fetal circulation. The basic difference between fetal circulation and postnatal circulation is the function of gas exchange. In fetal circulation, gas exchange occurs in the placenta, whereas in the postnatal circulation, with the first inspiration, expansion of the lungs, the process of gas exchange shifts from the placental circulation to the postnatal circulation. Now the fetal circulation. Blood oxygenated in the placenta and goes through the umbilical vein, enters the fetus through the umbilicus and joins the portal vein. There is a low resistance bypass channel from the portal vein to the inferior vena cava known as ductus venosus. Majority of the venous umbilical blood goes to the inferior vena cava through the ductus venosus. Only a minority enters the liver and goes to the inferior vena cava by means of hepatic veins. On the other hand, the blood from the superior extremity, that means from the head and upper limbs, goes to the right atrium directly. Now the right atrial blood comes mainly from the superior vena cava and the inferior vena cava also. Now, inferior vena cava stream has got several components. One, from the umbilical venous return. Second, from the aortic veins. Third, from the veins of the lower extremities and kidneys directly. The blood in the right atrium collected from these sources undergoes division into two streams. One third goes to the left atrium through the foramen ovale, and one third mixes with the venous return from the superior vena cava. The majority of the superior vena cava blood in association with the small amount of blood of umbilical venous return goes to the right ventricle, and right ventricle pumps blood to the pulmonary arterial trunk. A majority of blood goes to the pulmonary circulation. Only a minority of blood mixes with the blood coming from the left ventricle and goes through the descending aorta. And the largest branch of the descending aorta is the umbilical artery that comes from the anterior division of the internal iliac artery. Now, what's about the left ventricle? Left atrial blood comes from the right atrium as well as from a small amount of blood from the pulmonary veins that mixes, goes to the left ventricle and ejected in the ascending aorta and supplies the head and upper extremities. That's all regarding the fetal circulation. Now the changes of the postnatal circulation are colossal in pulmonary vascular resistance associated with expansion of the lungs. Second, an increase in systemic vascular resistance. Third, evolution of the low resistance placental circulation. Fourth, an abrupt increase in the left atrial pressure that is translated into the functional closure of the foramen ovale. And fifth, the functional closure of the ductus arteriosus at about 12 hours following birth due to the increase in the systemic arterial oxygen tension. এটা নতুন করে বলার কিছু নেই। প্লাসেন্টা, umbilical vein, ductus venosus, inferior vena cava, a small portion in the liver, right atrium, right ventricle, pulmonary trunk, lungs, pulmonary veins, left atrium, foramen ovale, left atrium, left ventricle, aorta descending, ductus arteriosus, and the systemic circulation in the umbilical arteries. Changes at birth, I have already told. A colossal fall in pulmonary vascular resistance associated with expansion of lungs, a pronounced increase in the systemic vascular resistance associated with the elimination of the low resistance placental circulation. Third, a decrease in pulmonary blood flow in right atrium due to evolution of the umbilical venous return. Fourth, abrupt increase in the pulmonary blood flow, which is promptly translated into an increase in the left atrial volume and pressure. Fifth, functional closure of the valve of foramen ovale. Sixth, constriction of the ductus arteriosus at about 12 hours following birth in response to an increase in the systemic arterial oxygen tension. Now, congenital heart disease. What is it? Dynamic, anatomic, cardiac, or cardiovascular anomalies that originate in the fetal life and exist since birth and alter in the postnatal life or postnatal development. Convergence of advances in the field of pediatrics, medicine, and cardiovascular surgery helped a cross subset of increasing population, especially adult population with congenital heart disease in adulthood. Now, the basic questions we should have to face for diagnosis of heart disease and then the congenital heart disease. Does the child have a heart disease? First point. Second, is it congenital in its nature? Third, what type of lesion? And fourth, what is the severity of the lesion? When to suspect congenital heart disease, respiratory distress, cyanosis, and failure to thrive. Respiratory distress, cyanosis, and failure to thrive. These three symptoms or triad of symptoms should raise the possibility of congenital heart disease. Now, Alexander is Nadas. Nadas's criteria সাধারণত ইউজ করা হয় the presence of the heart disease in a child. It has got both major criteria and minor criteria. What are the major criteria? Major criteria includes systolic murmur grade 3 or more in its intensity, diastolic murmur, cyanosis, congestive heart failure. These four. Minor systolic murmur with the intensity less than 3. Abnormal second heart sound, abnormal ECG, abnormal X-ray chest, and lastly, the abnormal blood pressure. Now coming to each point, the one major or two minor criteria constitute the diagnosis of the presence of heart disease, not necessarily the cyanotic or acyanotic heart disease. Major criteria. The systolic murmurs with an intensity of 3 or more. Systolic murmur के एक क्षेत्र दुটো भागे categorize करा जाए. Ejection systolic murmur and pan-systolic murmur. Pan-systolic murmur is almost always associated with the presence of heart disease, with the exception of severe degree of anemia as well as severe degree of pyrexial illness. But ejection systolic murmur is not always pathological. Ejection systolic murmur with the presence of thrill may signify a congenital heart disease or heart disease. So systolic murmurs, ejection systolic, pan-systolic is almost always pathological with the exception of severe anemia and the severe pyrexial illness, and ejection systolic murmur with the presence of thrill, that is the grade 4 or more, is a criterion for the presence of heart disease. This is the pan-systolic murmur. Details se jaar darkar nahi. This is the classical example of the ejection systolic murmurs. The second criteria, diastolic murmurs. Diastolic murmur is almost always pathological. Diastolic murmur is almost always pathological, except in presence of severe systemic hypertension. Except in presence of severe systemic hypertension, then the root dilatation may produce diastolic murmur. So, the exception of systemic hypertension, as well as in case of severe degree of anemia, there may be a diastolic murmur. Otherwise, diastolic murmur is almost always pathological for the diagnosis of heart disease. It is the second major criteria. Then the cyanosis. সাইনোসিসকে আমরা তো ডিফাইন করেইছি, দুটো ভাগে ভাগ করি, ট্রু সাইনোসিস অ্যান্ড সিডো সাইনোসিস। ট্রু সাইনোসিসকে আমরা দুটো ভাগে ভাগ করি, হেমিগ্লোবিন সাইনোসিস অ্যান্ড হিমোগ্লোবিন সাইনোসিস। হিমোগ্লোবিন সাইনোসিসকে আমরা আবার সেন্ট্রাল সাইনোসিস, পেরিফেরাল সাইনোসিসে ভাগ করার চেষ্টা করি, এবং সেন্ট্রাল সাইনোসিসের ক্ষেত্রে কার্ডিয়াক সাইনোসিস বা পালমোনারি সাইনোসিস। সুতরাং সেন্ট্রাল সাইনোসিস ইজ আ ফিচার অফ the presence of heart disease, peripheral cyanosis usually not. Now, central cyanosis may be a result of the right to left shunt, or central cyanosis may be a result of the impairment of the gas exchange in the lungs in the setting of the chronic severe pulmonary disease. So, with the exclusion of chronic severe pulmonary disease, the presence of central cyanosis is a criterion for the presence of the heart disease. And how would you differentiate these two? That means cyanosis arising from the cardiovascular system or cardiac pathology, or cyanosis arising from the lung pathology. Recognition of cyanosis. Oxygen content of the blood is dependent on hemoglobin concentration. Second, oxygen saturation. Third, blood flow. Cyanosis usually appears when the oxygen saturation falls below 86%. Cyanosis is more easily seen in the polycythemia. Acrocyanosis versus central cyanosis. Acrocyanosis means the peripheral cyanosis or digital cyanosis. Now, cyanotic detection of cyanosis. The hypoxemia test, pulse oximetry, etc., as well as the arterial blood gas analysis. The detection of cyanosis is done by hypoxemia test, pulse oximetry, and the arterial blood gas analysis. What is the hypoxemia test? This is very crucial for differentiation between the intrapulmonary pathology or intracardiac shunt, which one is responsible for the cyanosis. এটা পড়ে hyperoxia test, hypoxemia test, hyperoxia test means on room temperature if tolerated, first measure PaO2, then 100% FiO2 oxygen supplementation. Must note site of measurement, pulse oximetry is not applicable in this case. The result. If there is no increase or increase in PaO2 less than 100, it is likely that heart disease is present. If the increase is in the range of 100 to 150 millimeter of mercury, there is a possibility. And if it is more than 150, the heart disease is unlikely. Hyperoxia test, first on room temperature, initial assessment of PaO2, then oxygen supplementation, 100% FiO2, then after 10 minutes, PaO2 increase less than 100 millimeter of mercury, heart disease is likely. 100 to 150 possibility, and more than 150 the lung disease is the possibility. And the fifth point of the major criteria, this is the presence of the congestive heart failure, evidenced by poor feeding, failure to thrive, and fatigue. Poor feeding, failure to thrive, and fatigue. The congestive heart failure is also a marker or major criterion for the presence of the heart disease, with the exception of severe hypoglycemia. Severe hypoglycemia may produce or severe anemia, again anemia subjectively থাকছে, severe hypoglycemia or anemia in infant and neonates. In infants and neonates. The major criteria: systolic murmur, diastolic murmur, cyanosis, congestive heart failure. Minor criteria. The second heart sound. Second heart sound is the most crucial component of the Nada's criteria, but it should be placed in the minor criteria group because this is the subjective assessment in the process of auscultation. No one is perfect in his or her auscultation. That's why it is placed in the subgroup of minor criteria. The ACE2 has got two components. The first component is aortic valve closure. The second component is the pulmonary valve closure, that is the A2 and P2. With inspiration, P2 is with expiration, P2 is somewhat earlier, A2 is somewhat earlier, and P2 is also somewhat earlier. That's why with the expiration, there is superimposition of both A2 and P2 producing a single sound, but with inspiration, there is a split of the second head sound, that is a gap between the A2 and P2. What is the auscultation hallmark of the split? Usually, the auscultation hallmark of split is 50 milliseconds, 30 milliseconds. Pulmonary component, নতুন করে বলার কিছু নেই, aortic component পেরিয়ে যাচ্ছি, সেমনি valve mechanics বলার কিছু নেই। Normal, expiration single, inspiration, this is the split, wide and variable, split, wide and fixed. Classical example is atrial septal defect, right bundle branch block with right heart failure, and third, total anomalous pulmonary venous connections. Then the paradoxic split, aortic stenosis severe degree, and the single S2 severe aortic stenosis or severe pulmonic stenosis. 30 milliseconds. The auscultation benchmark is 30 milliseconds. Separation between the aortic component and the pulmonary component should be at least 30 milliseconds. But during the bedside exam with our common stethoscope, it's very difficult to assess the 30 milliseconds. It is the phonocardiographic findings. Others, that means other minor criteria: abnormal ECG অ্যাবনর্মাল ইসিজিতে আমরা দেখার চেষ্টা করি রাইট ভেন্ট্রিকুলার হাইপারট্রফি, লেফট ভেন্ট্রিকুলার হাইপারট্রফি অ্যান্ড অ্যাক্সিস ডেভিয়েশন। কিন্তু এক্ষেত্রে মনে রাখা দরকার যে ইন কেস অফ চাইল্ড ভোল্টেজ ক্রাইটেরিয়া ইজ নট অ্যাপ্রোপ্রিয়েট ফর দ্য diagnosis of ventricular hypertrophy because ventricular hypertrophy is or voltage is mitigated by or influenced by the hyperviscosity, the dyselectrolytemia, placement of the leads in the chest wall and the size of the chest wall. Second, the abnormal X-ray, and third, the abnormal BP. These are all included in the minor criteria. This is the common clinical cause already described. Workup should be done on the basis of first, whether acyanotic or cyanotic, then whether pulmonary arterial blood flow is increased or not, then the site of malformation, either left ventricle or right ventricle, then which ventricle is the dominant ventricle, and lastly, whether pulmonary hypertension is present or not. The cyanotic, increased pulmonary arterial blood flow, total anomalous pulmonary venous connections, truncus arteriosus. Second, normal or decreased pulmonary arterial flow, dominant right ventricle, pulmonary hypertension present, right to left shunt. Dominant right ventricle, pulmonary hypertension absent. That means that this is the Epstein's malformation. Dominant left ventricle. Now, acyanotic, normal or decreased pulmonary arterial flow, shunt absent, malformation originating in the left side, malformation originating in the right side, increased pulmonary arterial flow, একই জিনিস left to right shunt. Classification, acyanotic কে দুটো ব্রড ক্যাটাগরিতে যদি নিয়ে আসি, একটা প্রেশার ওভারলোড, একটা ভলিউম ওভারলোড। Now, pressure overload or volume overload means right L or shunt, ASD, VSD, PDA. Pressure overload, ventricular outflow tract obstruction, pulmonic or aortic valvulation, aortic coarctation. So, acyanotic, pressure overload, volume overload. Cyanotic, decreased pulmonary blood flow, Fallot's nephrology with pulmonary atresia or pulmonary atresia itself, tricuspid atresia, single ventricle with the pulmonic stenosis, increased blood flow, transposition of the great vessels, truncus arteriosus, and on occasion the total anomalous pulmonary venous connections. Adults with the congenital heart disease, ACHD, the new terminology. Anatomy versus physiology. On the basis of anatomic complexity and physiological consequences, the adult congenital heart disease can be subdivided into several groups. Before going to discussion into the subgroups, we want to know how congenital heart disease is present in the adulthood. Congenital heart disease that is present at birth with the converging and advanced management in the field of medicine, pediatrics, and cardiovascular surgeon have resulted in an substantial increase in the presence of the congenital heart disease by three categories. Number one, non-operative or native. Number two, surgical palliation. Number three, physiologic repair. Native or নন অপারেটিভ কিচ্ছু বলার নেই। সেকেন্ড হচ্ছে হোয়াট ইজ সার্জিক্যাল প্যালিয়েশন, দ্যাট মিনস the surgical procedures or intervention in an attempt to increase the pulmonary blood flow or decrease the pulmonary blood flow, keeping the patient with the existing cyanosis. This is the palliation. This is the palliation. That means surgical palliation. That means increase in pulmonary blood flow or decrease in pulmonary blood flow, keeping or allowing the cyanosis and the other malformation intact. Now, what is the physiologic repair? That means total or near total division of the systemic pulmonary circulation, keeping the child cyanosis free. So, adult congenital heart disease comes from the one native or non-operative, second surgical palliation, third the physiologic repair. Now the complexity. Anatomic complexity and physiological changes have subdivided the adult congenital heart disease as simple, that means this is the anatomic complexity, isolated small AST, small VST, or mild isolated pulmonary stenosis, etc. Second, the moderate complexity, that means aorta to left ventricular fistula, anomalous pulmonary venous connections, ostium primum type of AST or others. Third, the great complexity or complex cyanotic congenital heart disease defect, unrepaired or palliated, double outlet ventricle or procedures such as Fontaine procedure for Physiology or pulmonary atresia or truncus arteriosus. So simple, number one. Number two, moderate complexity. Number three, greater complexity or great complexity. And the anatomy complexity, class 1 simple, class 2 moderate, class 3 complex. Physiologic stage A. Physiologic state A means NYHA functional class of 1, no hemodynamic or anatomic complications, no arrhythmias, normal exercise capacity, normal renal, hepatic, and pulmonary function. B. NYHA functional class 2 symptoms, mild hemodynamic complications, mild valvular heart disease, trivial or small shunt, arrhythmia, but that does not require any treatment. Lastly, abnormal objective limitation to the exercise capacity. C. NYHA functional class 3, substantial hemodynamic consequences, moderate aortic enlargement, venous or arterial stenosis, end organ dysfunction, pulmonary hypertension, arrhythmia, but controlled with the drugs. And D. NYHA class 4 symptoms, severe aortic enlargement, arrhythmia refractory to treatment, and severe hypoxemia, severe pulmonary hypertension, Eisenmenger syndrome, and the refractory end organ function. The tracking early disease progression, stage A, stage B, and subclinical decline. Then the stage C, stage D, just diagrammatic representation দেখে যাচ্ছে. Management. Congenital heart disease is no longer just a pediatric specialty. It has transitioned into a dynamic adult medical continuum requiring lifelong physiological late clinical staging. That is staging, AP staging. That means anatomy complexity and physiologic consequences. না 12টা ক্লিনিক্যাল প্রোফাইলের ক্ষেত্রে আসতে পারি, যেটা ম্যানেজমেন্ট ডিপেন্ড করছে। ফার্স্ট প্রোফাইল class 1, class 2, class 3. Stage A, that is 1A, 1A, 2A, and 3A, then 1B, 2B, 3B, then stage C, that is the decompensating 3C, sorry, মানে কি বলবো, C, 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 2, C, 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 3, আর 4, D, D, D. এই যে 12টা কমপ্লেক্সিটিস আছে, পুরো ম্যানেজমেন্ট প্রোটোকলটা ডিপেন্ড করবে এই ক্লিনিক্যাল প্রোফাইলটাকে অ্যাসেস করার পর। Now management of adult congenital disease. আগে একটা কথা বলা হয়েছিল যে Eisenmenger syndrome and Eisenmenger complex as well as Eisenmenger physiology. Eisenmenger physiology means the development of pulmonary hypertension with resultant reversal of flow from the right to left. This is the Eisenmenger physiology. Any intracardiac or intravascular shunt like ASD, VSD or PDA plus pulmonary hypertension Eisenmenger's physiology. Reversal of shunt from the right to left due to development of the pulmonary arterial hypertension is the Eisenmenger physiology. Eisenmenger syndrome, that means any intracardiac or intrapulmonary shunt with development of the pulmonary arterial hypertension and the reversal of the shunt. But Eisenmenger complex, that means classical VSD with reversal of shunt due to the pulmonary arterial hypertension. So, Eisenmenger physiology, Eisenmenger syndrome and Eisenmenger complex একটু সূক্ষ্মভাবে বিচার করলে আলাদা। ম্যানেজমেন্টকে আমরা অ্যাসেস করার চেষ্টা করব অ্যানাটমি, ফিজিওলজি আর ম্যানেজমেন্ট স্ট্র্যাটেজি। অ্যানাটমি কি হতে পারে? নেটিভ লিশন or unoperative lesion, whether congenital or not. Second হতে পারে কি যে operative lesion in the form of surgical palliation or in the form of physiological repair. Then goes to the physiology, that is the chronic cyanosis, pulmonary arterial hypertension and the intracardiac loading condition. These all will constitute the therapeutic strategy. Now, the consequences of the congenital heart disease. Presence or persistence of the central cyanosis may lead to development of chronic progressive hypoxemia and erythrocytosis that may result in hematologic, neurologic, renal, metabolic and rheumatological complications. Now the complications of the hematologic. First, the erythrocytosis with hyperviscosity and consequences. Then the iron deficiency, then the bleeding diathesis. So erythrocytosis, iron deficiency and bleeding diathesis and the hyperviscosity. Hyperviscosity may result in faintness, dizziness, fatigue, altered mental status, impairment of the neurocognition, as well as generalized malaise and the myalgias. Second, the hemostatic abnormality that is usually mild and superficial, manifested by easy bruising or purpuric spot, but may be severe enough to produce epistaxis, hemoptysis, or massive intraoperative bleeding. Neurological manifestations that may include stroke, either hemorrhagic stroke or the embolic stroke, and the resultant consequences. Renal complications include proteinuria, hyperuricemia, and the chronic renal failure. Musculoskeletal osteoarthropathy, digital clubbing, and generalized muscle pain or arthralgia as a result of either hyperuricemia or as a result of hyperviscosity syndrome. These are the complications, these are the physiological processes. Now, second, the pulmonary hypertension. Pulmonary hypertension কে আমরা দুটো ভাগে ভাগ করি, hyperkinetic pulmonary hypertension, fixed and irreversible pulmonary hypertension. Hyperkinetic pulmonary hypertension means pulmonary hypertension due to increased pulmonary blood flow, such as in the initial stage of AST, VST, or PDA. And the fixed pulmonary hypertension is the irreversible pulmonary hypertension means the organic obliterative changes as well as interstitial fibrosis in the pulmonary vascular bed that produces the fixed pulmonary arterial hypertension with resultant pressure overload on the right side of the heart and the congestive heart failure. And this is the intracardiac loading systems, that means resulting ventricular load from the pulmonary hypertension. Now the management strategy. Native lesion বলা দরকার নেই, operative history বলা দরকার নেই, cyanosis, pulmonary hypertension, loading condition, diagnostic imaging, details এ যাচ্ছি না। এখন আইসেনমেঞ্জার সিনড্রোমের সিমটমস কি হতে পারে? এক নম্বর সিমটমস হচ্ছে ইজি ফেটিকেবিলিটি অ্যান্ড এক্সারসাইজ ইনটলারেন্স, দু নম্বর হচ্ছে ডিসনিয়া অ্যান্ড এক্সারশন, তিন নম্বর হচ্ছে চেস্ট পেন। সায়েন্সের মধ্যে ডিজিটাল ক্লাবিং অ্যান্ড সাইনোসিস and Eisenmenger complex may also produce arrhythmias and sudden death. Now the management protocol. Anatomy, native congenital lesion, operative, unoperated palliation, repair, physiology, pulmonary hypertension, cyanosis, intracardiac loading, management, medical, hematologic, neurologic, renal, rheumatologic, and the operative, operate, reoperate, further palliation, and the physiologic repair. Question. Medical management. Impact of cyanosis already described. Hematologic, neurologic, renal, and rheumatologic. Cyanosis, heart failure, arrhythmia, and pulmonary hypertension managed accordingly. Now the management of the hematocrit or erythrocytosis. Hematocrit more than 65%, symptoms of hyperviscosity, no. Observation, yes. Dehydration, volume replacement, no. Phlebotomy. Hematocrit less than 65%, symptoms of hyperviscosity, yes. Iron deficiency, no. Phlebotomy, yes. Iron replacement. And symptoms of hyperviscosity, no. Observation. Bleeding, spontaneous, mild, avoid NSAIDs and nasal oxygen. Number 2, serious, transfusion, platelet, cryoprecipitate, or fresh frozen plasma according to the situation. Perioperative estimation of the hemoglobin, platelet count, prothrombin time, and partial thromboplastin time. Hematocrit more than 65%, managed accordingly. Decreased platelet, intraoperative platelet transfusion, decreased platelet and increased platelet or increased partial thromboplastin time or prothrombin time, intraoperative fresh frozen plasma, because cyanosis may impair certain coagulation formation in the liver as well as produce a both qualitative and quantitative defect in the platelets. যাচ্ছি না, অপারেটিভ ম্যানেজমেন্ট আগে বলা হয়েছে ইনিশিয়াল রিপেয়ার করো যেটা আনঅপারেটেড কেসে, অথবা রিঅপারেট করো, অথবা এনফোর্সমেন্ট অফ দ্য সার্জিক্যাল রিপেয়ার or এনফোর্সমেন্ট অফ দ্য ফিজিওলজিক্যাল রিপেয়ার। ইন্ডিভিজুয়াল হার্ট ডিজিজগুলো পরে পড়ানো হবে, আপনার দরকার নেই। আচ্ছা, এবার বলে দিই কয়েকটা কথা, কি কি টপিক বাকি আছে। হাইপারটেনশন, peripheral arterial disease, and myocarditis as well as pericarditis.